Hi, my name is Pauline Liao, and I will be doing the diabetes workshop today, which is an update on diabetes in older adults. I don't have anything to disclose. And this is my outline. I've taken most of the talk from the update from the American Diabetes Association that released this year, their standards of medical care for the treatment of diabetes. And this section is from the older adults section with this reference that I've listed on this slide. So what they really want to emphasize is individualization, is assessing each patient and seeing how much they can do, how much they understand, what's their hypoglycemia risk, and what other conditions do they have, and then recommending a treatment based on their situation. So I'll go over what the goals for A1C and glucose monitoring are, and also the recommended treatments, and to consider what beyond diabetes, what's their cardiac status and what's their renal status. And also, have they met their metabolic goals, which is really their weight goals. And then what lifestyle changes that can be recommended, and then the medications. So diabetes, and especially in older adults, older adults with diabetes are at higher risk for neurocognitive decline. So it is important to screen for early detection, and you can use a mini mental exam or these other tests, mini-cog and the Montreal Cognitive Assessment. And also people who don't have good control of their diabetes or have had diabetes for a longer time have associated cognitive decline. And with this cognitive decline, it affects their ability to perform their self-care tasks. They might not be able to monitor their sugars as well, or be able to adjust their insulin doses appropriately. They might not be preparing their meals like they used to, and they may not be able to recognize hypoglycemia symptoms. And so what can slow the progression of cognitive decline? So controlling blood pressure and cholesterol, and certain lifestyle, like keeping active, regular exercise. And these medications have been shown in observational studies and in post hoc analysis to slow the progression of cognitive decline. And these are metformin, pioglitazone, and GLP-1 agonists. So what are the hypoglycemia risk factors? Older patients are at higher risk for hypoglycemia, and one big risk factor is if they are not aware that they have hypoglycemia. So usually when your sugar drops below 70, you get sympathetic symptoms such as increased heart rate, sweating, tremor. It's generally an uncomfortable feeling, but some patients lose this awareness. Usually if patients have frequent hypoglycemia, they're going to lose this awareness. And then they might not have any symptoms until the sugar drops very low, and then they will need assistance. So patients with liver disease or kidney disease are at higher risk for hypoglycemia because these are the main organs that produce glucose. Mostly the liver is the main organ for gluconeogenesis, but the kidney also is responsible for about 10% of gluconeogenesis. Also with kidney disease, medicines will have longer duration, increasing the risk of hypoglycemia. So medications that increase insulin secretion or increase insulin action are going to increase the risk of hypoglycemia. These are insulin, obviously, sulfonylureas, and the meglitinides, which are shorter acting but still cause an increase in insulin. And then reduced functional status is a risk factor for hypoglycemia. So there is a hypoglycemia risk assessment tool that looks at 6 factors, and these factors are older age, above 77, a later stage chronic kidney disease, the use of insulin, the use of sulfonylurea, having any prior hospital visit for hypoglycemia, and any prior visit to the ED in the previous year. This tool was developed by a research scientist at Kaiser, and it looked at ED data in over 200,000 patients to come up with this tool. And the tool was validated in over 1 million members in the VA and other Kaiser sites. So this is the tool. So the strongest predictor for future hypoglycemia is really any prior hospitalization or severe hypoglycemia going to the hospital. So these are, and assigning a point system, and it's so these are the strongest risk factors. So the people with low risk are having no prior hypoglycemia, people without insulin or sulfonylurea use, and a younger age, or who do not have kidney disease. And then this is also who have not gone to the emergency room, even though if they were on insulin. So intermediate risk would be, for example, an older patient who's on insulin and has CKD, but has not been to has not needed an ER visit. So at the visit, you want to ask, is the patient having hypoglycemia? How often? Can they tell that they're having hypoglycemia? And I like to ask, at what level is their sugar when they're having hypoglycemia symptoms? Because it's not very helpful if they have hypoglycemia symptoms, but then their sugar's already in the 50s. So ideally, they want to start having hypoglycemia symptoms when they're in the low 70s or high 60s, so then that they will be able to treat it. And then you want to ask, what are their triggers, or what precipitated the hypoglycemia? Was it they were doing exercise, or they didn't eat as much as they thought they were going to eat and had injected insulin, or they just forgot to eat, or they missed a meal? And then patient education is very important. So they should be taught what are the symptoms of hypoglycemia, and then how to treat it, and then establishing a routine. So maybe not skipping meals, trying to keep each meal consistent so that they're consistent in size and consistent in the carbohydrate content. This is especially important if they're on insulin. Otherwise, they should be able to adjust their insulin doses. But if they're not able to know how to adjust their insulin doses, then the meals should try to be consistent. And if they're taking their medications correctly, they should be injecting insulin and then eating right away. Or if they're in a sulfonylurea, that should be taken with food, because if they take it and then they don't eat, then their sugar could go low. And then also to educate them on the exercise effect on glucose. Cardio activity usually will cause the glucose to drop. So if they're going to take a walk or they're going to go to the gym, they should be aware to maybe carry some snacks, or carry their glucose monitor so that they can check their sugar. And then also to be aware that their sugar may drop low during exercise, or at the end of exercise, or even later on after exercise. So now there's continuous glucose monitors are pretty commonly used, and they are recommended for all type 1 diabetes patients and also type 2 patients who are using basal bolus insulin regimens. Glucagon treatment should be recommended, and family members should be trained on how to give glucagon and when to give glucagon to a patient. Typically, it's when a patient has low sugar and is not responsive. If a patient's responsive and able to drink juice or eat something, then glucagon is not necessarily needed. But if a patient cannot do that, then someone has to intervene and then give glucagon. And then if a patient has unawareness, then the way to reestablish that awareness is by relaxing on the sugar control, letting the sugars go up a little bit higher. And then when the sugar goes low, they will have the hypoglycemia symptoms again. And then for some patients, they will need their regimen de-intensified, which is either reducing the insulin doses or reducing some medications so that they don't get hypoglycemia. So there's two main glucose monitors on the market, or these are the two that are most commonly used. They're Freestyle Libre and Dexcom. So they each are pretty small, and each of them can either come with a receiver that looks like this, or you can download an app and get the readings on the phone. So Libre now has up to Libre 3, like a third generation, that lasts 2 weeks. The Libre 3 is pretty small. They like to say the size of a penny. The Libre 2 is the size of a quarter. And these are very easy to use. It's all in one piece, And the Libre 2, you had to scan the sensor with your phone or the receiver to get this reading. But the Libre 3 doesn't need to be scanned. It will automatically send the glucose readings to either the reader or the phone. And when you get this reading, there's this number, and then there's this arrow, the trend arrow, which will tell the patient, is your sugar trending upward? Is it flat? That will be a straight line, or is it decreasing? And the CGMs have about 15 to 20% error, or 10 to 15% error, depending on the sensor. And there's also a 15 to 20 minute delay. So that's something that the patients have to be aware of. So if they feel that their sugar is dropping, the reader might say 80, but they could actually be lower because if it's dropping very quickly. So they have to confirm low sugar readings or very high sugar readings with the glucometer. The Dexcom is similar. It lasts only 10 days, so it has to be changed a little bit more frequently. The G6 comes in two pieces like this. The sensor is this flatter part, and then this is the transmitter that sends the glucose readings to the phone or to a receiver. But the G7 looks similar to the Libre, where it's all in one piece and it doesn't need a transmitter. And then they both alarm when they're low or they're high. So it is a good safety feature that when the sugar is dropping quickly, the patient will be alerted. So Medicare has also relaxed the requirements for a CGM. It used to be that they had to be on insulin 3 times a day, but now any insulin use and the patient will qualify for a CGM. So this is a hypoglycemia treatment that's recommended, 15 grams of simple carbs. So it could be glucose tablets, which are 3 to 4 tablets, or a piece of candy, or a small amount of juice. And then they should recheck their sugar in 15 minutes. But if they're not responsive, then a patient should be given glucagon. And they have to be aware that if they're on long-acting medications, hypoglycemia can occur again. So they need to keep monitoring their sugar. So these are the forms of glucagon. And I would say it's definitely improved. So in the beginning, there was this glucagon injection kit that came, it was powdered glucagon and needed to be reconstituted. So family members really did have to be trained on how to mix it and then how to give it to the patient. And this is all that was available for a very long time. And so now more recently came out pre-filled syringes that don't need to be reconstituted, and almost like an EpiPen where they can just be injected intramuscular to the patient. And then in 2019, 2 new forms came out, Gvo, which is glucagon, but that's shelf stable. It did not need to be refrigerated, and it's a subcutaneous injection instead of intramuscular. And then also nasal glucagon, which makes it much easier for a family member. It's just one spray in each nostril. And then this is a later Gvo pen where it's the needle's not even visible, so it makes it easy for someone to inject. And then now there is a glucagon analog that's available. And the glucagon analog is designed to have a longer half-life, about 30 minutes compared to only 6 minutes for regular glucagon, and also to be more stable in an aqueous solution. So, but one big problem is that not all of these formulations are covered by all insurances. So the patient has to help and find out which one is preferred, and then you can send the covered glucagon prescription to the pharmacy. So what are the treatment goals? The treatment goals are really based on a patient's functional status. So for somebody that's healthy and that has very few or stable illnesses and has intact cognitive function, then the goal is the same as a younger patient, and that will be 7 or 7.5. For someone who has intermediate or complex chronic conditions and maybe variable life expectancy, we relax the goal a little bit, and their goal would be 8. So an example of a chronic condition could be heart disease or CKD or COPD or heart failure that's stable or frailty. And then older adults with poor health and very complex health conditions, then they actually recommend not any specific glucose or A1C goals. And the main goal is to avoid hypoglycemia and symptomatic hyperglycemia. So very complex could be metastatic cancer, could be end-stage renal disease, or end-stage CHF. So A1C is the main thing that we monitor for a reflection of sugar control, but there are some limitations. So in Blacks, the A1C tends to be higher, but it's usually a small difference. So usually it's less than 0.4. And this is thought to be due to genetic differences in the red cell metabolism. Hemoglobin variance also will make the A1C not reliable. And usually in these cases, and also for sickle cell trait, the A1C is falsely low. So if you find someone with an A1C of like in the 4s or in the 5s who has diabetes, then you know that their A1C is not reliable. And then about 11% of Blacks in the US have this X-linked glucose 6-phosphate dehydrogenase variant that also causes the A1C to be not reliable. This causes the A1C to be falsely low by 0.7 to 0.8. Other causes of falsely low A1C will be anything that causes increased red cell turnover or production. And that's some examples are anemia, kidney disease, especially if they're getting erythropoietin treatment. Some HIV treatments cause a low-level hemolysis and will make A1C falsely low. Obviously, if they had recent blood transfusion, it's not their blood. And pregnancy also causes a lower A1C. There's really only one situation that causes a falsely high A1C, and that is people with low iron. So in these cases, the A1C may be higher than 5.5, but it's typically not over 6.5. So we shouldn't be making any false diabetes diagnosis with this. But iron deficiency anemia can cause a slightly high A1C. So generally, these are the glucose testing guidance. Is Medicare allowance is 1 time a day if a patient is not on insulin, and 3 times a day if a patient is taking insulin. But these can be increased. It just needs to be justified when you order their testing strips. And then the goals generally for a healthy patient, 80 to 130 pre-meal, 80 to 180 after meal or at bedtime. For intermediate health, it's a little bit higher, 90 to 150. But same 100 to 180 after eating. And someone with poor health, you just have a wider range, 100 to 180 before meals and up to 200 for after meals. The inpatient goal is generally below 140 to 180, but I think under 200 is also okay for inpatient. I wanted to show some sample CGM reports. So when somebody has a Libre or a Dexcom, you can download their receiver or even get a report from their phone, and it's very helpful. So this is a report from the Libre, and AGP stands for ambulatory glucose profile. So it will tell you how much the sensor is worn. So that's the CGM active. These are the goals, and they'll give you the average glucose, and then the glucose variability, which is really how much it's fluctuating, and then what the predicted or calculated A1C would be based on their sugar readings. So the goal would be to have your target range above 70%. So here, the goals are right here. So if you don't remember them, they have it listed here. The goal target would be to have someone over 70% in range. And then, of course, we want as less hypoglycemia as possible. So this is a sample. You can print out a whole bunch of different kinds of analysis and statistics, but I find the daily graphs to be the most useful because then you can look day by day and see what is happening. So for this patient, she's trending low in the early morning, but high after some meals. So, I recommended that she reduce her basal insulin, and then depending on the meal, she would need to take more bolus for these meals. So this way to help her recognize, like, what did you eat on this day? And on this day, she would have to increase the amount you took. This is a Dexcom report. It's pretty similar. They give you the average with also the time and range, how much is high, how much is low. This is how much are they wearing the CGM. And then they have a little bit more detail, you know, when did the alerts come on and at what sugar level. You can do this overlay, which I think looks a little chaotic, but you can have each day of the week superimposed on each other. So now I'm going to go into the treatment. So this is the treatment algorithm for that the ADA recommends. It's a bit wordy, but I will go through it. First, at every visit, it's recommended to go over what is a patient's lifestyle like, and what are the barriers in their lifestyle or maybe in their environment that may be interfering with attaining good glucose control. Like, you know, what is their life situation like? Are they cooking? What's their are they eating out a lot, or who's preparing their meals? And then it's recommended to go over this with each visit to so that a regimen can be updated or any adjustments made, and also to avoid treatment inertia. And then the two main things to look for are what are the comorbidities? And specifically, it's their cardiac status and their kidney disease, and then also have they met their weight goals? So it's really metabolic, cardiac, and kidney status. So for somebody who has known cardiac disease or is very high risk at cardiac disease, a GLP-1 with proven benefit, which I'll go over in the next coming slides, or an SGLT2 inhibitor with cardiac benefit. That these should be one of the first choices. For someone with heart failure, then an SGLT2 inhibitor is recommended, and also for somebody who has a later stage kidney disease, an SGLT2 inhibitor is preferred. As for somebody who hasn't met their weight goal, then a GLP-1 is preferred. So, and then they list these treatments for efficacy on reaching your weight goal. So for glucose lowering and reaching your weight goal, it's these GLP-1s, and then a little bit older GLP-1s, and then neutral would be metformin and DPP-4. And then in this box is the efficacy for glucose lowering. So GLP-1s are very efficacious for glucose lowering. DPP-4, not very much. And then for someone who hasn't met their weight goals, you can refer them for nutrition counseling, medications for weight loss, and also consider metabolic surgery, which is very effective, not just for weight loss, but for diabetes. So lifestyle modification, it can be challenging because in the older patient, they may have altered taste, they may have poor appetite, they may be losing weight already, and they may not be preparing their meals. So they might not be able to control what meals they're getting if they're having a meal delivery or if they're relying on a family member to prepare their meals. One recommendation is make sure they get adequate protein because older patients tend to lose muscle, and so having adequate protein in the diet can be helpful. Now, I like to keep things simple. I avoid extreme diets or fad diets, but it's really trying to avoid processed carbs, eating more vegetables and protein. I think meal replacement shakes are okay if they're not hungry and they just want to have a protein shake instead of a meal. I think that is okay. But I do recommend that everybody avoid all sugar drinks. And there's just so many sugar drinks now. And so that includes juice, ginger ale, sweet teas, coffee creamers, or coffee flavor shots, or energy drinks, because when you drink sugar, it just makes controlling the sugar very, very difficult or impossible. And then for exercise, a mix of aerobic, weight bearing, and resistance is good. And some examples that I'll give patients is to walk 10 minutes after a meal. It doesn't sound like much, but it does help in reducing or blunting the postprandial meal rise. I recommend 44 steps a day as a minimum. And this number came out of a study in older women patients where the average age was 72. And they showed a 40% reduced mortality in women who walked 4,400 steps a day compared to women who only got 2,700 steps a day. So 4,400 to me is the magic number that they should get. This benefit was capped off at 7,500 steps a day. So they don't need to walk 10,000 steps a day, but I do try to get them to walk 4,400 steps a day. Another example, since we live in the city, I'll just say walk around the block twice, and that's about 8 blocks. And so if they could do that in the morning, and if they can do that in the afternoon, then that's a pretty good walk. And now there's a lot of YouTube exercise videos available. So they can just search a diabetes workout for the elderly. There's also a bunch of chair workouts that can get the body moving. So metformin is still first line. It reduces hepatic glucose production, increases insulin sensitivity. There's a low risk of hypoglycemia. Lactic acidosis is very rare, so metformin can be used until the GFR drops to 30. Though if it's below 45, it's recommended not to start it. But if somebody is already taking it, then reduce the dose to half if their GFR drops below 45. So that would typically be 500 metformin BID. And now you don't have to hold it anymore for venous contrast studies if the GFR is above 30 and they don't have any acute kidney injury. But it's still recommended to hold for arterial contrast studies, such as if they're going to go for cardiac cath. It may cause B12 deficiency, so this should be checked periodically, like maybe once a year. And the main limiting factor, I think, is that some people get GI symptoms with metformin. There is an extended release version that I think improves some of the symptoms, but some people still can't even tolerate the ER version. And in some people, it causes weight loss. And if somebody doesn't need to lose weight, then this can be concerning. So after metformin, really the next line will be a GLP-1 or SGLT2 inhibitor. So I'll talk about GLP-1s first. These delay gastric emptying, they increase fullness, and they tend to cause weight loss. And these are okay to use with low GFR. So it's really one of the only medicines that's not insulin that can be used in someone with advanced kidney disease. So I've highlighted in red the cardiovascular trials that had positive results. And the GLP-1s with positive results that have reduced cardiac events are liraglutide, semaglutide, and dulaglutide. And then neutral effect is this lixisenatide and exenatide. So no harm, but no benefit was seen. But these are the three that have positive cardiac risk reduction. And also in these trials, there was no increase in pancreatitis or medullary thyroid cancer. So this year, or in the past year, I should say, semaglutide was also shown to have benefits for reducing cardiac risk in patients without diabetes and improving kidney or reducing kidney events in people with diabetes. So these are some added benefits. The SELECT trial, which was published last December, enrolled patients who had a BMI 27 or greater with cardiac disease, but who did not have diabetes. So 2/3 of the patients had pre-diabetes, a mean age of 62, a mean BMI of 33, and the follow-up was 40 months. They were titrated up to 2.4 milligrams a week. That's the highest dose. And a 20% reduction in cardiac events was seen. The absolute, this is impressive, but the absolute risk reduction is about 1.5%. It was, I think, 6.5 versus 8%, the cardiac risks, the cardiac events. And then the patients on semaglutide also lost a significant amount of body weight. And so after this trial, then Medicare does cover it for this indication. So for a patient who maybe doesn't have diabetes, who may have prediabetes, but who's obese and who has heart disease, then semaglutide now is covered by Medicare. Now, the FLOW trial was published in May and enrolled people with diabetes and CKD. And these were the CKD inclusion criteria. So GFR 50 to 75 with proteinuria, or GFR 25 to 50 with microalbuminuria or proteinuria. So a mean age was 66, mean GFR 47, and the mean urine albumin to creatinine ratio was 567. The mean follow-up was 3.4 years. The study was actually stopped early because of a benefit that was seen. And there was 24% reduction in kidney events, and kidney event was defined as GFR going below 15, or the need to start dialysis or require a transplant, or more than a 50% reduction in their baseline GFR. It reduced their urine albumin creatinine ratio, and there was 18 similar reduction in MACE that was seen in previous trials. So tirzepatide also became available this year, and this was also showed very impressive reductions in A1C and weight. It's also a once-a-week injection. It also stimulates insulin secretion and reduces insulin resistance. There's 2 sets of trials, SURPASS, which are for enrolling patients with diabetes and showing consistently a 2 to 2.5 reduction in A1C, and SURMOUNT in patients with obesity, showing up to 20% weight loss. This is at the higher doses, and reduced liver fat content also was shown. So the cardiovascular trials are anticipated to be completed later this year, but so far the studies show improved blood pressure, improved lipid profile, and improved inflammatory markers such as CRP. So hopefully this is also going to show that cardiac events are reduced. SGLT2 inhibitors are once daily oral tablets. There's a low risk of hypoglycemia with these medications. They have a diuretic effect, so it can lower blood pressure also. It reduces weight a little bit, not as much as the GLPs, but usually they lose a few pounds, and it does have kidney benefit. So the label says you can use up to GFR to 30, but I know a lot of nephrologists are using it even below 30 for renal benefit. The glucose lowering benefit is going to be less at the lower GFRs. And then there are very good data for improving heart failure. But they do have some adverse effects. The main one is that it can cause urinary symptoms. So in an older patient, it can worsen incontinence. There is an increased risk of urinary tract infections and genital infections. And then this can also be a problem if someone is incontinent, and then they can get more skin infections with the urine, that's the incontinent urine. It can cause hypotension, which can increase their fall risk. And then there is an increased risk of diabetic ketoacidosis. And for that reason, it's only approved for type 2 diabetes, not for type 1. And the risk of DKA occur whenever there is metabolic stress. So that could be with a severe infection. It could be in MI or a stroke. It could be if they've missed their insulin doses, with heavy alcohol use, and also with a major operation. So some physicians recommend holding SGLT2 inhibitor 3 days before a major operation, because there are some reports of DKA following major operations. Oh, and another con is the cost. These medicines are not cheap. So they have very good data for heart failure and kidney, but in red are the ones that have shown reduction of cardiac, reduced MACE. So it's empagliflozin and canagliflozin. All of them improve heart failure and also benefit the kidneys. So dapagliflozin did not, it was not significant, but it reduced a cardiac death that was driven by heart failure reduction. But all of them, like I said before, reduced hospitalization for heart failure about 30%. The other medications in the algorithm, pioglitazone, has durable A1C reduction, meaning that the effect is long lasting. It has very easy dosing. It's once a day. It's very well tolerated. There's really no GI side effects, and it doesn't cause hypoglycemia. But it can cause weight gain and edema. So it's not recommended in use for stage 3 or 4 heart failure. It may increase the risk of fracture. The absolute risk is pretty small. It's about 2 to 4%. And cardiovascular benefit has been shown in these trials. DPP-4 inhibitors are very well tolerated also. They also don't cause hypoglycemia. They're also once a day, easy to take, and you can use them with reduced creatinine clearance. They have renal dosing. Linagliptin, actually, you don't have to reduce the dose, so it's just 5 milligrams a day, even with advanced kidney disease. They're weight neutral, so they don't result in any weight loss. But the A1C reduction is very, very small. It says 0.6, but sometimes it's even less. And these are expensive, and there's no cardiac benefit. So I think DPP-4 inhibitors, they're sort of third line because they don't have the benefit of for cardiac and for renal that we see with the other medications, and also the glucose lowering is not as good. So this is what's coming up I think these are in phase 3 trials now, either phase 2 or phase 3. Retatrutide, which is a triple agonist, it's GLP-1, GIP, and glucagon, and mazdutide, which is GLP and glucagon receptor agonist. So activating the glucagon receptor can increase energy expenditure and also improve hepatic fat metabolism. And this is even despite their hyperglycemic effects, because I was a little surprised when I heard this at first, because I was thinking, well, we give glucagon to increase insulin, but then it has these other benefits, and glucagon also reduces food intake. So now also, in the pipeline are SGLT1 inhibitors. So SGLT1 inhibits or SGLT1 is responsible for glucose reabsorption in the intestine. So inhibiting that will block some of the reabsorption. The SGLT1 is also highly expressed in the myocardium. So inhibiting that may reduce apoptosis and reduce cardiac apoptosis and reduce oxidative stress. And then there are some dual inhibitors also. Also in the pipeline is a weekly basal insulin. Insulin icodec is actually already approved in the EU, Canada, China, and Australia, but it was denied by the FDA earlier this year. I think the company is going to resubmit it, but it didn't get approved because of the risk of hypoglycemia. And then there's another weekly basal insulin also being developed by Lilly. So this icodec is made by Novo Nordisk, and this one is made by Lilly. So because you would have to dose your whole weeks of insulin all at once. So for someone who's on, say, glargine 10 units a day, then their icodec dose would be 70 units per week. So I think there's a little bit of adjustment of getting comfortable with taking that much insulin all at once. So beyond glycemic control, it's also controlling blood pressure. If someone has good functional status, the goal is 130/80. If they're not in good health, then 140/90. The statin therapy is still recommended even in older adults if this is the time to benefit. In one study, 2.5 years. So if the life expectancy is going to be more than that, then a statin is recommended. And then aspirin therapy is recommended only for secondary prevention, not for primary prevention. So when should a regimen be de-intensified? So if someone's having a lot of hypoglycemia, or if their glucose is fluctuating very widely. So if they're having sugars like from 60 to 350, you know, or if they're making mistakes with their dosing, like they're taking their rapid acting instead of their long acting at night. And if they don't have a consistent eating schedule, or if the patient requests it or their caregiver requests it, they say, you know, 4 times a day insulin is too much for me. Can we make it easier? These are reasons to de-intensify. So some ways to de-intensify is to reduce the number of insulin injections, maybe move the basal insulin injection to the morning instead of the nighttime. I will usually do that if they tell me they fell asleep and then they missed their nighttime dose. And really, they can take their basal anytime they want. It's just, and then whatever time they set, then it should be the same time every day. If they had a sliding scale, then either I'll simplify the sliding scale or just even discontinue their sliding scale. And then there's a lot of combination medications available, so that can reduce pill burden. And then there's even an insulin GLP-1 combination that can reduce injections. For type 1s, it's really not possible to de-intensify because they need insulin. So, for that, I think we just have to offer support to caregivers because they're the ones who will end up giving the injections. So this is an example of an intensive regimen. So someone who's on a long-acting insulin and then rapid acting with each meal, they might be on a sliding scale, which means that if they're high, they're going to take some extra. And then if they might be on a GLP agonist once a week, and then an SGLT2 inhibitor, and then maybe they're on metformin twice a day, and then plus their other medicines. So most people with diabetes are on a statin, ACE or ARB, blood pressure control, and that's only just for diabetes. So then they might have other heart conditions or other health conditions that they're on medications for. And it gets very expensive. So especially these newer medications are very, very expensive. I wanted to go over some ways to de-intensify insulin regimens. So there is premix insulin, which is a mixture of NPH and rapid acting. They do have NPH with regular, but those have a higher risk of hypoglycemia, so I wouldn't recommend using those premixed. But for the NPH and rapid acting, there are 2 main brands. They're Novolog premix and Humalog premix. So Novolog mix has 70% NPH, 30% aspart. Humalog mix will have 50% NPH, 50% Lispro, and the 75-25 is 75% NPH, 25% Lispro. It's twice a day dosing, and it's using the NPH that peaks in 4 to 6 hours to cover the lunch meal. So when they take it at breakfast, the NPH will peak around 12 to 1 o'clock, and then they wouldn't need to take insulin for their lunch. But the lunch has to be small since they're not using any rapid insulin at that point. It's just the peak of NPH. But it's easy because it's only 1 insulin. So for patients who have a lot of medicines, it's 1 less copay. And there's also no worries about getting their insulins confused. It's just only 1 insulin. But they do have to keep their meals consistent, and they have to eat a small lunch. It doesn't have to be big, but they have to eat something. If they don't eat lunch at all, they can get hypoglycemia around that early afternoon time. And then if their meals are too big, their sugar is going to go high after the meal because these doses are only either 25%, 30, or 50% of rapid acting. So for someone who's injecting, say, 20 units, then only either if they're on the 75-25 mix, then only 25% of that is rapid acting. That's going to cover the meal at the time of injection. But also another suggestion is they could just take this premix for dinner time. If dinner is their main meal, then I think this is a nice way to de-intensify the regimen. They just have 1 dose of a premix. It'll cover their dinner, and then they'll have NPH overnight to help cover or to help reduce their morning sugar. So there are basal and GLP-1 combinations. There's 2 available, and then these are once-a-day injections. And these use fixed proportions of basal with the GLP-1 agonist. So there's a Soliqua, which is glargine with lixisenatide, and then Zoltofi, which is degludec with liraglutide. So the dosing starts at 15 units of glargine and then maxes out at 60 glargine, and then that uses the max dose of the GLP-1. For Zoltofi, the max dose of the basal is 50 with the max dose of liraglutide of 1.8. So I think it could be a good second line add-on for a patient who has a higher A1C who then needs insulin, and then they get a little bit of GLP-1, that will offset some of the weight gain that's common with insulin and also help reduce the appetite. And they get some so that they get some GLP-1 effect. But if it happens that they're already on these doses with these doses of GLP-1, then you can also convert them. But I would say in most cases, we want to try to max out the GLP-1 effect. And then if they're on lower doses of long-acting insulin, you can't max out the GLP-1 effect with these medications. So inhaled insulin is another option. This will reduce injections, and this also reduces hypoglycemia between meals because it has a more rapid onset and it also has a shorter duration. So it's a more rapid offset than the rapid-acting insulins. But they can't have any lung disease, and you need to do PFTs at baseline and after 6 months to make sure there's no decline in FEV1, and then annually after that. And also, this only comes in these set doses. So for people who need to really adjust their insulin doses more than this, then with Afrezza, you're limited to 4 units, 8 units, and 12 units for mealtime. I mean, they could double up. So if someone's using 20 units, they just do 2 blister packs and inhale it. So I wanted to mention about insulin pumps in older adults. I generally don't recommend insulin pumps, starting an insulin pump in someone older, because you really have to assess, would they be able to do these things? Can they change their sites every 2 or 3 days? Do they understand the concepts of carb counting, a meal bolus versus a correction bolus? Would they be able to adjust their pump settings? Like if they call me that their sugar went low and I tell them, well, I want you to reduce your basal rate from this time to this time, would they be able to do that over the phone? So they have to be a little bit tech savvy to understand, to be able to adjust and use the technology. And then also they have to be aware of, be able to troubleshoot. So let's say when their sugars are high for many hours, it could be because the tube is occluded or something malfunctioned, and then would they know what to do, which is typically changing out the site, putting a new site, changing out the tubing, and then also giving an injection so that you just bypass all that, all the tubing and just inject the insulin. So, but they have to be aware that this could happen and know what to do. So for patients who are already on the pump, then you have to evaluate, can they still manage their pump on their own? And then what I think might not be obvious is that in type 1 patients, there is a higher risk of DKA when they're on the pump. And this is because with the pump, they're getting such small amounts infused every hour. So even just a few hours off the pump, they could be behind on their insulin very quickly and then go into DKA. I think this is less of an issue with people wearing continuous glucose monitors, because then they can be alerted more quickly that their sugars are very high, and that's a clue that their insulin is not being infused. But before, when people were just relying on finger sticks and they might not be testing frequently enough, then they can go into DKA without even knowing it. And also regular visits are needed. So if they're getting their insulin pump supplies through a diabetes supply pharmacy, and Medicare is covering these, but then they also request your notes every 3 to 6 months. So they need to be coming in to see you because these pharmacies ask for your office notes. And then if they haven't been in over 6 months, there's no office notes to give, and then they won't get their supplies. So for transitioning care, typically for inpatient, we only use insulin because non-insulin therapies might not be on the formulary, and there could be some unexpected procedures. So, a lot of these medicines have to be held before procedures. So it's just easier to be on insulin. It's predictable. and it can be held, or it can be adjusted pretty easily. So for transitioning, you can start with a weight-based dose, like a basal of 0.3 units per kilo per day, or work off their home regimen. And when you do that, I just recommend considering what their A1C was before admission. So like, was their home regimen, were they controlled on their home regimen? But you can still work off what they were taking at home. And then on discharge, you have to evaluate their ability and what support they have when you recommend what they should go home on. So I have some cases to go over. And these are actually cases I saw in the hospital recently. So it's a 71-year-old man with a long history of diabetes and CKD who was admitted with a severe hypoglycemic episode. He had a seizure on the subway. And the story was that he was actually had a high sugar following lunch in the 300s. And so he gave himself some extra Lispro before leaving. And then during his commute, I think he was starting to feel woozy. And then he actually had a seizure on the subway. And then EMS was called. He was brought to the hospital. And then it turns out he was started on dialysis 6 months ago. And his insulin was not adjusted since then. He's on 14 units every morning and 7 units with meals. And his A1C was 5.9. He wasn't using a CGM. He didn't really like use. He tried it. He didn't like it. But he's only testing once a day. And he was getting pretty low sugars in the morning, sometimes in the 70s or 80s. And his BMI is 25. So in the hospital, insulin was held. And he had 45 the following morning. And this was even 24 hours after, more than 24 hours after his last glargine dose. But later in the day, he did go up to 270. And then the next morning, he was actually at 192. So it does seem like he needs, we can't just discharge him on nothing. But what should be recommended? So we actually recommended to reduce his insulin sort of by half. So he was sent home on glargine 7, half his usual dose, and then Lispro only for eating starchy meals, 4 units. He wasn't my patient. I think if I was able to follow him up with outpatient, I would be curious to see if he could just be managed on glargine and GLP-1, or maybe even just GLP-1 alone, because GLP-1 also does reduce fasting glucose levels. But without that follow-up, I didn't want to take the chance that he would have high sugars. So he's comfortable with insulin, so I think he'd be okay with just reduced doses. I did recommend that he start using a CGM, or at least more frequent glucose testing if he's not going to wear a CGM. So another case, a 75-year-old woman with also longstanding diabetes and also end-stage renal disease, and she's admitted with a stroke. Her A1C was 9.5. At home, taking glargine 40 units and Lispro 20 with meals. She's 80 kilos, and she's aphasic, probably not able to swallow, and she was started on tube feeds. And the tube feeds are for 18 hours. So her hospital course, glargine was reduced to 20, which was really a weight-based dose, and then rounded down for her end-stage renal disease. And her sugars on that were still a little bit high. And then regular insulin every 6 hours while the feeds are running. So her first dose would be before the first feed, and then every 6 hours. And then her sugars were not horrible with that. But then she did have a low sugar in the hospital because the feeds were held when she had to go for an imaging study. So the staff just has to be aware that when someone's on feeds and has already gotten their insulin, that they need to run D5 to keep the sugars from running low. But then when she goes home, these are factors that have to be considered. She'll probably go to rehab for a while, and then in rehab she can just be on insulin. But things to consider will be, what would her diet be like? Is she going to be eating, or is she going to go home on feeds? And also, what will her support be? Is she going to be doing insulin herself, or will somebody be there to help her with her medications and her meals? So another case, this is the last case, A 78-year-old woman with type 2 microalbuminuria and bipolar. And she's on a lot of medications, even just for diabetes. So Detamir 30, aspart before meals, acarbose, metformin, and liraglutide. And then she has other medicines for her bipolar and for cholesterol. And her A1C is 6.2, and her CGM looked like this. So she's going a little bit high after meals, but then low during the day, low in the morning, right, and low after some meals. So her initial adjustments, so I changed her daily liraglutide to weekly semaglutide. So that got rid of one daily injection, reduced her Levemir, her Detamir insulin to 14, and discontinued her acarbose. And then on follow-up, the semaglutide was titrated to 2 milligrams per week, which is the maximum dose, and then reduced her Detamir more to 8 units. And then this was her CGM. She's still going high after meals, so couldn't get rid of that. But she's not having hypoglycemia. Her A1C 7.1, which is okay for her age, and she also lost 15 pounds. So I'm hoping at her next visit to discontinue the Detamir insulin, and then she would just use the aspart for meals, and then she could dose after eating so that she knows how much she's eaten. One problem before was that because of her depression, sometimes she wouldn't eat or she wouldn't eat that much, and that was what was contributing to the hypoglycemia after her meals for some of the meals. So this way she could adjust her dose and give it as soon as she's done eating and she's known how much she has to cover. So just to mention, prediabetes in the older population does not need to be treated because the majority do not progress to diabetes. And in this population, just focus on lifestyle changes, diet, exercise, and weight loss. But you can consider medication in obese patients or in patients who you're following their A1C and then it just keeps creeping up. And you can consider semaglutide in someone with prediabetes and heart disease and obesity because now this is a covered indication. And then oral glucose tolerance test is still recommended if it just tells you exactly where a patient is. You know, is it, you know, do they have impaired fasting glucose? Do they have impaired glucose tolerance, or have they crossed into diabetes? So in summary, everybody has to have their treatment goals individualized, and it's really based on their level of functioning. So you just can't have a really intense regimen in a patient that is not going to be able to do that. Avoid the side effects that impact the elderly most, and that's hypoglycemia and falls. And then consider their other conditions, and specifically it's heart disease, kidney disease, and obesity. Metformin is still first line, and then second line will be GLP-1 and SGLT2. I would also say a lot of these medications require prior authorization, and many of them will ask if they have tried metformin. So even in just that situation, a lot of times you have to use metformin first. And then for people who have higher sugars, to start with, a basal GLP combo, I think is a good addition. And then third line, insulin, pioglitazone, and a secretagogue. So I have a post-test question. 72-year-old with diabetes comes for follow-up. She does not have a history of cardiac disease, but she wants to know how she can reduce her risk for cardiac events. She's on metformin, 1 gram twice a day, and low sartan 50. On exam, her blood pressure is 132/80 and a BMI of 31. Her A1C 7.1. She has a GFR of 85, a little bit high triglycerides, 256, HDL 52, LDL 115. So what do you recommend adding specifically for her question of reducing her cardiac risk? So semaglutide, empagliflozin, fenofibrate, atorvastatin, or aspirin. And the answer is a statin. So adding a statin to get the LDL, and the goal is 70 for people with diabetes, will have a greater risk reduction compared to adding semaglutide, empagliflozin, or fibrate. And since she does not have a history of previous cardiac event, aspirin is not recommended.